Okay, cool. Thanks everyone for joining. Welcome to AI for Healthcare webinar. And this number 11. So we have passed 10 webinars already, and I'm super thrilled to welcome our speaker today, Dr. Jenna Wiens, Associate Professor of Computer Science Engineering at University of Michigan, as our today's speakers. And Jenna is also Associate Director of their Artificial Intelligence Lab and co-director of Precision Health at the University of Michigan. And her research lies at this intersection of machine learning and healthcare, and she received her PhD more than 10 years ago from MIT and received numerous awards, including NSF CAREER Award and MIT Tech Reviews as an Innovator Under 35 in 2017, and also Sloan Research Fellowship in Computer Science in 2020, and recently is a Humboldt Research Award and in recognition of her research up to date. And she's a pioneer in this AI for healthcare with a strong focus on ensuring machine learning model not only being effective, but also responsible and unbiased. I still remember her paper in Nature Medicine, Do No Harm, this roadmap paper about responsible machine learning for healthcare. It's really a foundational framework. I encourage all the students who want to do research in AI for healthcare to read that paper and use that as like a template to guide their AI research and innovation in clinical practice and while addressing real world challenges. So without further ado, let's welcome Dr. Wiens to give her a webinar about white code, black box, navigating pitfall using AI to augment diagnostic decision making. Thanks.
Great. Well, thank you so much for Jimming for that kind introduction, and thank you for inviting me to come and speak today at the AI for Health uh, webinar. So this talk titled "White Coat, Black Box," I have to give credit to Dr. Brian Goldman. This was inspired by his podcast, which is titled "White Coat, Black Art," which runs on the CBC. So in addition to the roles that Jimeng mentioned in terms of serving as the Associate Director of the AI Lab at CSC, which consists of 25 faculties and about 100 PhD students, I also supervise and mentor my own research group. So these are all PhD students studying various aspects of AI and healthcare and machine learning in healthcare. But I'm not really here to pitch you on AI for health today. Instead, I want to talk a little bit about some of our experience working in this space and navigating the pitfalls. But first, I want to take you back to 2014. So I had just completed my PhD and had started as a brand new assistant professor in computer science. And, I was super excited about how machine learning was going to change healthcare. And at that point in my career, I thought at least 90% of the problem was cool machine learning. The type of machine learning you can publish in NeurIPS and ICML. And all we needed was the right algorithm. And surely once we had the right algorithm and we published it, we'd be able to start saving lives. And this is really a problem in our field. Many computer scientists and machine learning researchers envision impacting clinical care going something like this. So over my career, I've spent more and more time thinking about the integration aspect of AI in healthcare, and really thinking about how clinicians use AI to make decisions. At this point, we have well over 30 clinical collaborators. We've worked with over a dozen hospitals. My students shadow clinicians in hospitals, so we spend real time in hospitals meeting with both clinicians and patients. And I helped start a nonprofit organization, Machine Learning for Healthcare, that hosts a yearly meeting between clinicians and ML researchers. And at this point, I'm super excited to say that we've integrated two algorithms at Michigan Medicine that are being used in clinical workflows. And we have a third study that's underway right now with a randomization piece focused on readmissions. But I can tell you it wasn't as easy as just throwing it over the fence to our clinical collaborators. So in terms of technical directions, we work across a range of areas within machine learning. And a lot of our earlier work really focused on risk stratification and time series analysis. So predicting the progression of disease or predicting who's at greatest risk of an adverse outcome. And as we develop these models, more and more clinicians would ask us, well, why is this patient at risk, right? What is the model using? And that led to a lot of work in explainable AI. And then once we started opening up the black box, and we realized what the model had learned, it led to a lot of work in mitigating spurious correlations or relying on spurious correlations. And then there was a shift. Clinicians stopped asking, why is this patient at risk? And started to ask, what can I do about it? How can I reduce this patient's risk? And this led to like another kind of shift or thread in our work focused on matching patients to treatments, which led to innovations in reinforcement learning and causal inference. While we make technical contributions to AI and machine learning, almost all of our work is inspired by by problems that arise in healthcare. So to this end, we publish in both more clinically oriented journals like JAMA and Alzheimer's and dementia, and in addition to the machine learning or CS venues. Along the bottom in this slide, I'm just showing you a sample of the different types of problems we work on within healthcare, from predicting risk of infectious disease to physical therapy at home. So we're not too picky when it comes to the type of problem. If there's a potential for impact and there's data and there's a technically interesting problem, then we're likely to work on it. So these problems really span healthcare from prediction and prevention all the way to treatment and management. And we even have, that's not on this slide, a project related to policy with CMS, the Center for Medicare and Medicaid Services. All right, so I can't tell you about all of this work, but what I am going to talk about is a specific thread. And this is in our a thread in mitigating bias in AI and specifically in diagnostic decision making. And a lot of this work this was all done in the context of diagnosing acute respiratory failure. A lot of this work is led by PhD student Sarah Jabour, but it's truly an interdisciplinary collaboration including my clinical collaborators, Michael Schoding, Alec Hazaruni, and Tom Valley. In addition to my collaborators in CS with expertise in human-computer interaction, Nikola Benovich, and computer vision, David Foey. Okay, so what is the problem we're trying to solve? Acute respiratory failure occurs when a patient is unable to breathe effectively on their own, and they need some sort of respiratory support. It's associated with significant morbidity and high hospital costs, and there are several underlying causes, but the three of the most common causes include heart failure, pneumonia, and chronic obstructive pulmonary disorder. However, identifying which of the three is the cause for the patient's symptoms, so the reason that they're experiencing this shortness of breath, is a really difficult clinical problem. It's estimated that up to 30% of cases, clinicians get the initial diagnosis incorrect. So this was exciting when our collaborators came to us with this problem. They said, you know, since clinicians do so poorly, there's real room for improvement. Can AI help? So we started with asking the question, can we train a model to predict the probability that a patient's symptoms are due to pneumonia, COPD, or heart failure. And importantly, these numbers don't sum to one because you can have any combination of these underlying diagnoses. So our study population consisted of patients from Michigan who required significant respiratory support and who had a chest X-ray performed. And in order to get ground truth, each chart was independently reviewed by multiple physicians, and then they were scored on a scale of 1 to 4 for each of the 3 diagnoses, and then these scores were averaged and thresholded. And I just told you that clinicians were really unreliable for this problem, but in this case, they have access to the entire chart. So it's a retrospective chart review, so they're able to go back in time and see how the patient was treated. Did their symptoms resolve? Did the treatment change and then the symptoms resolved? Ultimately to make that diagnosis. So in addition to looking at the chest X-ray, we also included data extracted from the electronic health record. So these are tabular structured data, including demographics, lab results, and vital sign measurements. And again, importantly, the model, well, the clinician reviewers had access to all of the data. The model only had data up until the time that the patient developed acute respiratory failure, with the idea being that that's when you'd want to make the diagnosis. All right, so in this project, we used a fairly straightforward model. So this was just a fused model that combined a learned representation of the EHR data and a learned representation of the chest X-ray to output this multitask prediction. And applied to a held out set of test patients from our cohort, the model performed really well. So here I'm comparing it to a physician on the same task, and we see that in most cases it does as well, if not better, than the physician. And this was really exciting. We published this several years ago, but we weren't done. What we really wanted to know was why, right? Why is the model doing so well? What is it using that maybe the physicians are missing in order to make its diagnosis? And specifically, when we looked at COPD, you can see here we're doing quite well with COPD. When we looked at where the model was looking on the chest X-ray, it kept highlighting this tracheal region here. And when we showed this to our clinical collaborators, they got really excited because they were able to point to this paper that was published back in 2017 that showed an association from this finding called saber sheath trachea, which is this narrowing of the tracheal region, and how this is associated or is a marker for severe airflow obstruction as associated with COPD. But what was really cool is that this is not typically considered by clinicians when they're making a diagnosis of COPD. Instead, oftentimes what they look for is this like hyperinflated lungs, this barrel-chested individual to diagnose COPD. So this was kind of a perfect example of how AI can augment clinicians, right? This clinician AI collaboration where the AI is looking for something that clinicians might not be paying attention to or trained to identify. But we didn't have to go too far before we realized that the model didn't always focus on regions we expected. So here is an example where the model has correctly classified the patient as having heart failure, and it is highlighting this region here as activated, which is the heart, but it's also highlighting this region over here. And in fact, this is a pacemaker. So the models learned this association that having a pacemaker increases the probability of heart failure. And when we showed this to clinicians, they said, is this a bug? And we said, no, it's not a bug. This is an association that's present in the data. But after a lot of discussions, we determined that it was a problem to rely on this pacemaker. Because if I could go in and perform a surgery and remove the pacemaker, the clinician's diagnosis wouldn't change, right? They would see, oh, because of the clinically relevant radiological findings of this enlarged heart on this chest radiograph, the patient has heart failure. But a model that's learned to rely on the presence of this pacemaker once I take it away could fail and could change its diagnosis. So this is where the presence of the pacemaker becomes a shortcut. And shortcuts are not new. They've been around for a long time. Here's an example that I like from the 1900s. So this is a picture of clever Hans, the horse that could do math. So it was widely believed, at least, that this horse could do math because whenever you asked him a math question, the horse would stomp out with its hooves the correct answer with very high frequency. But young psychologist Oscar Fungst discovered that the horse hadn't actually learned math, but the horse had just learned to read the reaction of the audience. So as the horse got closer and closer to the right answer, the audience would gasp, and then the horse would know that it had the right answer and it would stop. So whenever the horse was blinded, or if the horse was asked a question the audience did not know the answer to, the horse was no better than random. So the horse could not, in fact, do math. So here, the look on the people's faces as the horse got closer to the right answer was the shortcut. All right, so beyond pacemakers, one of the questions that we had once we had completed the first study was what other shortcuts might exist in these data? And the way that we define a shortcut is based on two things. And this is in part inspired by the work of Ellie Pavlik at Brown, where we really rely on both evidence, so there must be a spurious correlation with the outcome, and extractability. So I'll come back to extractability, but first evidence, right? So how might various perhaps sensitive attributes like biological sex or race end up spuriously correlated with the outcome, with a diagnosis, right? Is there even a possibility for evidence here? Because if we don't have this piece, then it's not a shortcut. I can't rely on your race or biological sex as a shortcut. Unfortunately, we don't have to dig too deep in the clinical literature to find all the ways in which data may exhibit such biases. So, for example, research has suggested that after an abnormal cardiac stress test, women are less likely to undergo any subsequent diagnostic testing. This in and of itself is harmful since it means women may not receive the care they need, but it also has important implications because now it's created a potential spurious correlation between biological sex and a diagnosis. We've also found disparities in common laboratory tests across white and Black patients. And oftentimes laboratory tests are used to make a diagnosis. So if you're not tested, you can't get the diagnosis. Here on the x-axis, I'm showing you the difference in testing rate between white and Black patients. So if you're above this dashed line, you're testing white patients at a higher rate. If you're below this dashed line, you're testing Black patients at a higher rate. And I'm showing in red data from MIMIC, so the Beth Israel Deaconess Medical Center, and data from Michigan Medicine, the teaching hospital associated with the University of Michigan, in blue. And we see really common trends across these two institutions across some of the most common laboratory tests used in the emergency department to make diagnoses. So there's certainly potential for a correlation, a spurious correlation between sensitive attributes and outcome. But what about extractability, right? How easy is it to tell whether or not someone is female based on their chest X-ray, right? If I can't extract this information from the chest X-ray, then no matter how highly it's correlated with the outcome, I won't be able to rely on that as a signal. So that was the first question we had asked. How easy is it to tell whether or not someone's female based on a chest X-ray? And in across 3 different data sets, so Michigan, that was our tiny data set of about 2,000 patients. Mimic and Chexpert, that's the Beth Israel Deaconess Medical Center data set, and Chexpert's the Stanford data set, have hundreds of thousands of chest X-rays. It was trivial to tell whether or not someone was female based on a chest X-ray. And in retrospect, this wasn't that surprising, but when we asked our clinical collaborators, do you think you could tell whether or not someone was female based on a chest X-ray? They were like, maybe, but it's not something we're really trained to do. It's not something we look for. So we thought that was interesting. And then we tested a bunch of other attributes, potentially sensitive attributes too, like age, which we found could also be identified based on a chest X-ray. And we even found a relationship between race and the outcome, although it wasn't as strong as that found by Judy Gachoya and others a couple of years later, where they found a very high correlation. Or a very high ability, a signal, race signal in medical images. So obviously this can create a problem if that correlation is spurious and doesn't hold across time or across populations. Then if the model is relying on these shortcuts, it can break down. And shortcuts based on race and biological sex are particularly worrisome, but there are other sources of shortcuts that can be just as detrimental when it comes to model performance. So consider these 2 images from the same individual, except for one small difference. Can anyone tell what it is? You can put in the chat if you have any idea what the difference is between these 2 images. The contrast looks the same to me. Yeah, so both images are taken from the same patient at the same time with the same machine. The main difference is in the pre-processing. So they're both pre-processed using a Gaussian filter, which smooths the image a little bit. The one on the left had a standard deviation of 0.4, while the one on the right had a standard deviation of 0.5. So the one on the right is a little bit blurrier than the one on the left, which I'm sure you can all appreciate now that I've pointed it out. So in all the times that I've presented this slide, no one has actually recognized that. But a model can recognize this trivially. It can recognize the difference. It can sort chest X-rays into what pre-processing was used almost perfectly. And this creates an issue when you start to pool data sets together, right? We're in the era of foundation models where we want to train models on lots and lots of data. So I want to combine the Chexpert data with the Mimic data with the Michigan data. But what if these data are pre-processed in slightly different ways? Or what if I don't even know how they're pre-processed? And there are different case mixes, right? Maybe at one hospital, I'm more likely to see a type of viral pneumonia than another hospital because of differences in where the patients are. So this is a problem. It's a problem that is that we want to fix. So given the ease with which these models can latch onto shortcuts, we investigated approaches to mitigate this behavior. And in particular, we were kind of surprised, but it hadn't been done yet. How well does a simple transfer learning approach do at mitigating these sorts of shortcuts? And when we explain this to our collaborators, we kind of described it as it's similar to how clinicians will use similar radiological findings across chest X-rays to diagnose different diseases. So the setup is a standard transfer learning setup where I have some target task. So I want to diagnose whether or not someone has congestive heart failure. But my target task might consist of a data set that is very small and potentially very biased. And I assume access to a source task data set. So these data sets do not necessarily overlap. So a different data set, but it's a data set that I've curated, but it's for a different task. So I have labels corresponding not to congestive heart failure, but to whether or not the patient has pneumonia. But I know with domain knowledge that there are some shared features across these two tasks. So very simple transfer learning approach, similar to pre-training, where I'm going to learn all my parameters on a source task of pneumonia, and then I'm going to swap out the source task for the target task, freeze all the layers of the encoder except for the last output layer. So this is just the linear layer, and I'll learn a new combination of those features based on my very biased target task. So this is a really simple approach, but it works surprisingly well. So here we had a training set where we had a really strong correlation between whether or not someone had a pacemaker and whether or not they were diagnosed with heart failure. And if we didn't use the transfer learning approach, we basically did no better than random on a test set where we broke this correlation. But the transfer learning approach was able to recover from it. And we found this held across many different types of potential shortcuts. So this idea of restricting the learned features in that last layer based on some source task that is learned based on curated data is really similar to the idea of a concept bottleneck model. So that was concept bottleneck models were proposed in 2020, and the idea is basically that I restrict or constrain the model to rely on specific concepts in making its prediction. But one of the problems with this is that, one, you need to have domain experts to pre-specify the concepts. In our case, with the transfer learning, we're kind of learning those concepts from a related task. But it's also constraining the model to just rely on the known concepts, right? And if I restrict the model in this way, and the clinicians don't enumerate something like saber sheath trachea, right, when listing out the known concepts, then I might not do as well as I could if I had incorporated these unknown concepts. So our proposed approach here essentially combines a concept bottleneck model with the ability to learn unknown concepts. So this would be the pathway to learning to incorporate or rely on this evidence of saber sheath trachea. So we essentially have this concatenation summation of these two linear predictions, where the first term relies on the known concepts, and the second enables you to learn U. But the problem is this could also incorporate shortcuts, right? So if we just learned this in the standard way, then any shortcut like pacemaker could get through there. So instead of just optimizing this using a standard loss function, we include a regularization penalty J based on our prior work that penalizes unknown concepts higher than known concepts. So it's essentially preferring those known concepts. And in this way, we're able to show that compared to either a completely unconstrained model where you're surely going to learn to rely on a shortcut and then fail when the shortcut's not present, or a concept bottleneck where you're really restricted to just the known concept, so you're more robust to the shortcut, we're able to outperform either approach without relying on the shortcut, but while still getting that advantage of those unknown concepts. All right, takeaways. How am I doing on time? 3:30, good. So takeaways from this section, deep learning applied to chest x-rays, susceptible to shortcuts based on sensitive attributes. Transfer learning can help, It's surprisingly effective at mitigating such shortcuts. Um, we've published, you can go and look at our GitHub for these approaches. We've published both of these approaches previously. But one of the things that is important to either approach is that one, it relies on either a known related source task and curated data in which I'm confident the spurious correlation doesn't exist, or it relies on known concepts, right, which can be difficult to obtain. So because of these limitations, we wanted to think more about how we could solve this problem and how we could go beyond just these computational approaches. And what we kept coming back to was these images. So this image that I showed you in the very beginning of the talk, where I have highlighted, or the model highlights the fact that it's relying on the pacemaker, right? This was the first kind of clue or indication that the model was relying on something that we didn't think it should be. So one question we had was, could clinicians use this information, this type of explanation in real time, to identify when the model was incorrect or relying on information it shouldn't be? And we focused on image-based explanations, in particular GradCam, because it's so widely used. I went online and within a few minutes was able to identify several papers published in clinical journals that use these sorts of activation maps or GradCam images, even in a 1D setting. I thought this one was interesting, where they're looking at an ECG tracing and looking at the activations across time. And when we went back to the original paper, so this was first posted online in 2016 and then published in ICCV 2017. It has well over 20,000 citations at this point. But if you go back and you look at the abstract or introduction, they talk about these 5 things that the model can do. And what's really interesting is the very last thing says it can, these visualizations, GradCam, can help achieve model generalization by identifying dataset bias, right? That's exactly the problem that we're trying to tackle. But when you go and look at what data they have to support this claim, it's this figure. It's this one figure with 2 example images. Here, the goal was to classify the image as containing a nurse or a doctor. So these are the input images. In the top image, we have a nurse. In the bottom image, we have a doctor. And then we have the so-called biased model that's predicting nurse in both cases. And it claims like, look, it's clearly biased because it's looking at the length of the sleeves in this case, and the length of the hair. Whereas in the unbiased model, it's looking at whether or not there's a stethoscope, which is a little bit confusing because there's a stethoscope in both images, yet it makes different predictions. So anyways, we weren't satisfied that this was enough to like just go ahead and deploy these explanations. We wanted to test this idea. So this hypothesis, our hypothesis was that real-time image-based explanations can help clinicians learn to ignore bad model advice, right, or incorrect advice. So to test this idea, we ran a large study with hundreds of clinicians. We recruited hospital physicians, nurse practitioners, and physician assistants. So these are all clinicians who commonly care for patients with acute respiratory failure. And we showed each clinician a series of vignettes of patients with acute respiratory failure, like the one shown here, including their presenting symptoms, physical exam, laboratory results, and of course the chest x-ray. And then we asked clinicians to make a diagnosis. So how likely is pneumonia contributing to the patient's heart failure on a scale of 0 to 100? How likely is heart failure contributing to the patient's respiratory failure and COPD? And then we also asked them, because it's one thing to make a diagnosis, it's another thing to make a treatment decision. So we also asked them to select which treatments they would administer. And typically you would administer steroids if the patient has COPD, antibiotics if the patient has pneumonia, and IV diuretics if the patient has heart failure, or none of the above if they don't have any of these. All right, we also had a model that predicted a likelihood of each of the underlying diagnoses. And in addition to that model, we had an image-based explanation. Here are the locations that the model is looking at when identifying the pneumonia, from least important to most important. Each clinician saw 9 of these patient cases. The first 2 cases served as our baseline where the clinician never saw the AI model. So no model, no explanation. It was just how well do clinicians do at this task on their own. And then vignettes 3 through 8, they were either randomized to see the model predictions alone. So here's what the model thinks versus here's what the model thinks plus an explanation for why it thinks what it thinks, that image-based explanation. And then this final vignette was akin or designed to be similar to a clinical consult where you would ask your colleague, what do you think? And it was a narrative explanation. So it was written by a human, by a clinician on the study team, and it was always right. So the clinical consult always said, here's what I think was always right, and here's why I think it. Of course, we didn't tell the clinicians that the clinical consult was always right. So for the vignettes 3 through 8, where the clinicians or participants were randomized to see either model predictions alone or model predictions plus explanations, they saw these 6 different vignettes. And in half of the cases, they saw a very biased model, and the other half they saw a standard model similar to what I talked about at the beginning of the talk with reasonable performance. The bias model was trained in such a way that it wasn't even accomplishing the task at hand. So we didn't even try to train it to predict pneumonia. Instead, we trained it on the task. One of the ways we biased it was training on the task of, is the patient greater than 65 or not? And then anytime the model saw a patient who they thought was over 65, it would say, yes, this patient has pneumonia. And if they were predicted to be lower than 65, no, this patient doesn't have pneumonia. And the idea here is that with the explanations, I'd be able to see that in a standard model, the model's looking at the lungs, that makes sense. When diagnosing pneumonia, it should be looking at the lungs. I trust the model. I'm going to go along with it. But when I see the explanation for this intentionally biased model, it's not going to make any sense because it's looking all over the place, that bone structure in particular, and I'm going to ignore the model. I'm going to say, this isn't really a good model. I'm just not going to use this when making my decision. So I like to show this slide because this was one of the first user studies I've ever done. And I was really naive in how long I thought it would take. Sarah was the student on this project, and I said, let's knock this out in a couple of months and move on. I can tell you it took at least a year to design this properly, all the randomization, and then it took 7 months to recruit the 457 clinicians who were mostly attendings and mostly at teaching hospitals. And the vast majority, 98%, practiced hospital medicine, which is exactly what we wanted. All right. So how did clinicians do? So remember, we had at baseline those 2 vignettes where they saw no AI. Clinicians were 73% accurate. So this is almost right in line with the number I gave you at the beginning of the talk, where in roughly 30% of cases, clinicians get it wrong. So this gave us confidence that we had set up the study correctly. Now, when we paired clinicians with the standard estimates, so the standard model, which was 76% accurate alone, so the model without any clinician input was 76% accurate. The clinician with the standard model was 76% accurate. So we didn't really see that improvement above either one alone. When we paired the clinician with the good model and the explanations for the good model, right? These explanations that make sense, that's where we started to see this human AI collaboration, where the model started to outperform the clinician alone and the model alone. But when we show clinicians these intentionally biased estimates, right? So anytime someone is over 65, for example, I'm predicting pneumonia, their accuracy tanked. So down to 0.62 or 62%. Now, the hope here is that by showing those explanations, we'll be able to get the performance back up. That was not what we saw. So clinicians were still affected by the model predictions, even though the explanations really should have indicated that the models didn't make sense. And we were hoping they'd recover to at least baseline. That was not the case. And what was really interesting was in the last vignette. So remember the last vignette, vignette 9 was this clinical consult. And there we showed that even though we gave the clinicians the answer 100% of the time with a beautiful written explanation for why the colleague thought what it thought, clinicians still ignored this advice nearly 20% of the time which I thought was interesting. But the main finding was this algorithm versus algorithm plus explanation. And what we really see here is that when the algorithm gets it right, then clinician performance improves, right? They're more likely to make the appropriate treatment decision. This is great news. But when the algorithm gets it wrong, clinicians are less likely, significantly less likely to make the appropriate treatment decision, and explanations do nothing to mitigate that harm. Explanations do not help in this case. So the takeaways here, model predictions affect clinician diagnoses. That's number one, right? If they were just always ignoring, if clinicians were always ignoring the AI, then we wouldn't see any differences here, but we do. Accurate models can help. Again, that's good news. Inaccurate or biased models can harm. In explanations, we did not find that the image-based explanations that are commonly used today sufficiently mitigate this harm. All right, so what does this all mean? Well, back in the fall of 2022, the FDA issued some guidance over when it treats software as a medical device or when it excludes software as a medical device, and in particular excludes certain software from being regulated as a medical device if it meets certain criteria. And one of those criteria include enabling such healthcare professionals to independently review the basis for such recommendations that such software presents. So there's many different ways to interpret this, but a common interpretation is that if I provide explanations, then I'm off the hook. And I think the thinking here is that explanations can help humans recognize bad models, and they can serve as a backstop against such harm. But our results show that that is not the case. So now one question is why, right? Why do these explanations not help? And after the study concluded, we thought a lot about this because it was counter to what we expected. We honestly thought that the explanations would help. They looked so wrong to us that we thought surely the clinicians will be able to identify the incorrect AI. But that wasn't the case. So we had to do a lot of thinking after the study concluded. And one of the things that we thought about was the fact that these were really local explanations, right? They're giving us an explanation on a per instance basis. Whereas what we really want in order to identify, I think explanations are most helpful prior to deployment. So they allow you to check the model before you release it. And for that, we really need a global explanation, right? We need some higher level explanation. So for example, a global explanation, if I had a logistic regression model, would tell me how much it's relying on each of the input features. Now, one way we obtain near global explanations, oftentimes with our electronic health record data, our models trained on EHR is with permutation importance, where the idea is I have some tabular data set that represents some number of features. So columns represent features, rows represent individuals. I get some predictions, and then I can compare that to ground truth and measure my performance. In permutation importance, I randomly permute each of the columns independently, pass it back through my black box F, get output predictions, compare those to ground truth, and see if the performance changed, right? With the idea being that if the performance drops, then it must have been the black box was relying on that feature. So in this way, we can get kind of rankings that give us a better sense of what the model is relying on. So closer, it gets us closer to a kind of global explanation. So that's what we really wanted to do, but in the image space, right? We might have these chest x-rays where we have ages associated with the individuals. And what we want to be able to do is just shuffle the age across individuals. But pixel level permutation doesn't make sense, right? I can't, individual pixels, I can shuffle those across the images, but they don't correspond to concepts. So I'm not really interested on individual pixel um, importance. What I want is concept importance. I want a way to shuffle the age. That was really difficult up until a few years ago with the text to image diffusion models, right? So now I can permute concepts in an image space by permuting in the text space. So for example, if I give Stable Diffusion this prompt, a male computer science professor giving a talk on Zoom to academic researchers, it might generate an image that looks like this. And if I want to now, if I generate a bunch of these images and I want to permute the sex of the professor across the images, I can just change the prompt, right? So now a female computer science professor giving a talk on Zoom to academic researchers generates a different image. So we use the same idea across chest x-rays. So we have these radiology reports, which we can augment with various attributes. And then it's as simple as just permuting the body mass index. So this is BMI across the text and then passing it through a text conditioned diffusion model to generate a new chest x-ray. And we see that it's added, in this case, the presence of body fat. Now we can do the same thing as we've done in the past with tabular data, where we compare the performance of a model in which the concepts have been permuted in the text space, and then we generate images that are then passed through our black box model to generate predictions, compare those to ground truth, and then use the drop-in accuracy to check for reliance on particular concepts or features. So the takeaways here, permutation importance at the pixel level doesn't make sense, but permuting in the concept space is possible, and text conditioned diffusion models can be used to indirectly permute concepts across images. So this work was published in ECCV 2024. What it really helps us do is, again, scrutinize those models before deployment, which I can't stress enough. All right, so wrapping up, I want to go back to this picture that I started with at the beginning. If I've learned anything over the last decade of my career, it's that if you want to impact clinical care, you can't just throw the algorithm over the fence and hope someone catches it. You really have to run yourself to the other side and engage with stakeholders, whether these are clinicians, patients, nurses, hospital staff and leadership. Not only can they help integrate the model, they can help you think of questions that you wouldn't necessarily think of, which can then lead to new technical insights. And it's by walking over to the other side and working with people in other disciplines that much of this work that you saw today came to be. So here I'm highlighting collaborators from just the past 2 years at Michigan. These are all people with whom we've published papers that have ended up in either clinical journals or health policy journals, but also top computer vision and machine learning venues. And it's by engaging with these experts in other disciplines that we can learn which solutions will actually have the impact that we want. And with that, I'll end by acknowledging my funding sources, and I'm happy to take questions.
Great, great. Fascinating, Jenna. Thanks for the surprising and actually quite very interesting presentation. So for the audience, please put your yeah, if you can ask question, you can directly ask question now or put in the chat. And so I can maybe get started with one question. When you do the JAMA paper you're presenting, there's the explanation actually. It's quite surprising to see that the clinician actually follow the algorithm's suggestion, even it's when you say it's clearly wrong. Do you think it's because of the in the imaging space, it's just intrinsically quite much more messier than if you just present some, I guess, discrete structure feature. It's a lot easier for them to distinguish, okay, this doesn't make sense. Or but image, I guess it's maybe more messier and harder to assess.
Yeah, I think that's part of it. What you're getting at, I mean, it was raised by others as well in terms of, well, what if I gave a text-based explanation, right? And with LLMs that can do this, but we kind of had that in the last vignette, right? We had a text-based explanation, and clinicians still didn't even follow the right advice. So it's this interesting balance, right? So I was surprised by how much the clinicians paid attention to the AI model and how little they paid attention to the explanation. So when we compared how much time they were spending on vignettes in which there was an explanation to vignettes in which there wasn't an explanation, there was no difference. So that tells me that they might not even be really looking at the image-based explanation in the first place. And this has really like changed my thinking about like relying on clinicians at the bedside. We can't rely on them to like recognize bad models at the bedside, because we did this survey as a web-based survey, right? So people sat down, they were eating their lunch, they had time to answer a survey. In a real clinical environment, you don't have that kind of time, right? You have a lot of demands, different demands on your time. So I think anything we can do to scrutinize the model ahead of time is so important. And then I think what we should be focusing on, instead of like helping clinicians ignore bad model advice, making sure that models are good before we deploy them, and then help them recognize good model advice, right? Like in the case of the last vignette,
Mhm.
we don't have a model that's 100% accurate, but if we did, clinicians would only listen to it 80% of the time, which is obviously suboptimal. So can we help clinicians recognize flaws in their own reasoning? And that's where I think explanations can really come into play. Yeah.
Yeah, this is fascinating. We have a question in the chat, considering how biased the data could be in healthcare, what kind of augmentation
Augmentation to
using?
use. Yeah, that's a great question. So this idea of spurious correlation, I mean, it's confounding, right? This has been known in statistics for a long time. There's many, many different solutions, right? The simplest solution would be matching, right? So for every female patient, I have a male patient that's matched. But the problem with that is that you can't always do matching. That doesn't always make sense, or you might be biased in many high dimensional ways, right? Not just in a single variable. Um, but so the PLOS paper that we had published that showed the like bias in lab tests, there's no machine learning in that paper. You can go and look at the paper. It's just what we looked at was what are the differences in testing rates? And the reason we did that is because so often we never even consider, like, how many times have you seen a model that's been trained on a matched cohort in a machine learning venue? We just don't do that. It's not common. We always throw in all the data that we have, right? And try to maintain everything. So what we had proposed, not augmenting data, but we had like an expectation maximization, so going all the way back to EM based solution that we had presented at ICML. So I didn't get a chance to talk about it in this talk, but you can go and look at it. It was published at this last ICML, so ICML 2024. And it's an expectation maximization based approach to deal with this problem of selective labeling or disparate censorship when one rate is tested less than the other. And it solves this problem of under testing
Hmm.
group.
Interesting. I think I thought one of my students, John, you want to clarify your question?
Yeah, back when I was uh, actively working in interpretability, there was a paper by MIT, I think called Maya. So they had like this idea of a multimodality interpretability agent. And what it would do is it would use, I guess, these new multimodal models that pair things with text um, and images. And so I think the base example that they had was some type of you're trying to classify dogs versus cats, but maybe your vision classifier isn't actually looking at a dog or a cat. And in these multimodal, these bigger, larger, more powerful foundational models, in some sense, could be used to just say, okay, it's clearly not this heat map is clearly not looking at the pixels of the dog or the cat. So it's using a spurious correlation, for example. I'm not sure if you've ever thought about doing something like that.
Yeah, it sounds really similar to like the idea of a concept bottleneck, right? And I worry what you'd miss is those unknown things, right? So if it was highlighting the tracheal region, that is strange compared to what clinicians normally look at. But we were able to go back through the literature. So maybe a foundation model would have that knowledge and be able to say, no, this makes sense. But I think it would really depend on your training data. I know that a lot of stuff that's been done using natural images does not work in clinical or medical images,
Hmm.
which really isn't that surprising, given how different they are. Um, but I think, yeah, we definitely need tools that can audit these models ahead of time. I think what I'm arguing for is don't rely on clinicians at the bedside. I just think that that's either like the explanation is going to fail or they're not even going to look at it. And you're going to get this automation bias. And you think, oh, but because we have an explanation, we're okay. And it's, yeah, it's not the right reliance. But yeah, it's a really interesting direction.
I guess maybe from the other side of just a follow-up question. I don't know if we don't have enough time because it's 3 already, but um, have you ever talked with these doctors and asked them like what would it take for them to trust a model? Because I'm assuming this is like that could be a different question in and of itself.
Yeah. Yeah, so when I was first on the job market back in 2014, and I was going around and, pitching AI in health, it literally was a pitch because I kept encountering people that didn't believe in machine learning, I had someone tell me I don't believe in predictive models. Um, and I was really taken aback by that. And I spent a lot of time like trying to convince like this idea of trust and explainability. And what the results of the JAMA study showed me was how far we've come because they're almost over relying now on the
Hmm.
models, right? They tank their performance. So it's not that they're not trusting them because they are listening to them. If you didn't trust someone, you just wouldn't listen to them, right? So I think that there are a lot of interesting kind of layers to this problem in terms of how clinicians make decisions based on the output of a model and in what contexts. That can inform how we build the model and how we build approaches to audit the model as well.
Hmm. Thank you.
Great.
So I think we have another question. I don't, Jenna, do you have a few more minutes to?
I have a call,
Okay.
but I'm happy to take questions offline. So if you guys want to email me, I'm happy to answer questions. I mean, this is an area that I'm really interested in, but I do have someone waiting for me
Okay.
in a Zoom room.
So
So.
in that case, let's just thank Dr. Wiens again for the fantastic talk, and we'll send those questions to you via emails, and you can follow up separately. Thank you, Jenna. This is amazing.
Bye.
Thank you. Bye.